Hello, I'm Zero CEO Jamie Bryce, and welcome to the most impactful week in the movement to end prostate cancer. You now have exclusive access to informative and dynamic sessions, interactive presentations, and lots of downloadable educational materials. Plus, you can connect and chat with participants and presenters from wherever you are. Please join me right now for the virtual Zero Prostate Cancer Summit.
Thank you for tuning in to Zero's 2021 Virtual Summit. I'm Shelby Monier, Vice President of Patient Programs and Education here at Zero. Joining me today is Dr. Alan Bryce. Dr. Bryce is the Chair of the Division of Hematology and Medical Oncology at Mayo Clinic in Arizona. Dr. Bryce's research focuses on cancer genetics and novel therapeutics with a focus on personalized medicine. So thank you so much for being here, Dr. Bryce.
Well, thank you very much for that kind introduction. It's a pleasure to be here at the Zero Prostate Cancer Summit and to speak to all of you. You know, I know that there's a strong community of support of patients, patient advocates, and researchers who are very interested in this topic. So it really is a pleasure for me to be here today speaking with you. So what we're going to talk about today is PARP inhibitors in prostate cancer, what you need to know. I'm sure that most of you know that PARP inhibitors are now approved in prostate cancer. So I really want to go over the background data about, how did we get here? What does it mean? Where do PARP inhibitors fit for patients? And also, where are we going with this? Because, this is just the beginning, to be sure. So the big news, right, was that in 2020, we had 2 new PARP inhibitors approved for metastatic prostate cancer. Olaparib or Lynparza and rucaparib or Rubraca were both approved by the FDA after clinical trials show them to be highly effective for certain types of prostate cancer. Indeed, these 2 drugs were approved only 4 days apart in May, so it was a great weekend for prostate cancer. And both drugs are now available for patients. Now, these drugs are specific for certain genetic mutations. So we're going to talk about that. What are these genetic mutations? How does a patient qualify for these drugs? Who benefits from going on either Rubraca or Lynparza? Without question, though, these drugs are very important advances for the treatment of metastatic prostate cancer. And it's been a long time coming, frankly, for those of us in the research community and for the patients waiting for this. We've known this was coming. The research has been very strong. So it's great to finally be here. So what is a PARP inhibitor? So PARP inhibitors are drugs that target very specific mutations that can occur in some cancer cells. And what happens is that when these mutations are present, cancer cells will die if the PARP protein is inhibited, right? So you have a mutated cancer cell that has a ingrained weakness in it. And that weakness can be exploited if we come in and we inhibit this protein called PARP, leading to cancer cell death. So PARP inhibitors then are therefore effective in cancers with very specific mutations. And the key detail here is that approximately 20% of advanced prostate cancer patients will have these mutations. So to understand PARP, first we have to talk about genetics. So I'm going to back up a bit and talk about the genetics of prostate cancer. So at its core, cancer is a genetic disease, right? This is a disease where a healthy cell mutates to become a cancer cell. And it's all, one way or the other going to be about either mutations that the patient inherited from their parents or mutations that they accumulated over their lifetime. Some cancer-causing gene mutations, when they are inherited, are called germline mutations. Germline just meaning it's something that's in every cell in your body because you got it from your parents. And then, of course, potentially, you could pass it on to your children. Whereas some cancer-causing genes occur only in the cancer cell, and these are called somatic. I apologize there for the little typo, somatic, no E at the end. So gene damage in this case, in these somatic mutations, can occur naturally just because of age, right? So it's part of the process of cells aging and dividing and surviving over the course of many years that random mutations will happen. But the pace of mutation, the kinds of mutations can be accelerated due to environmental insults. So this can be things like UV rays from sun exposure or radiation from human-made causes. It could be tobacco, alcohol, other chemical exposures, right? All those various things that we know put a patient at risk for cancer. What we're really saying is that those things cause mutations in cells, and those mutations then lead to cancer cells. In prostate cancer, one of the key findings, papers that really changed the dynamic of the conversation was this paper published in 2012. And I'm just showing you the pie graph from this paper. And what they looked at here was they took a group of men with metastatic prostate cancer and they examined their germline genetics. So that is the genes they inherited from their patients. And in med school, I was taught that maybe 1 to 2% of prostate cancer was due to family inheritance. And the reason we said that is because that represented the low risk disease population, which is most prostate cancer patients. But what this paper showed is that in the high risk disease population, the frequency of the patient having a cancer risk gene in their bloodline, in their family, was 10 to 12%. And that's much higher, obviously. You're talking 10-fold higher than the textbooks used to tell us. And what you see here is that there is a pattern to it. The most common mutation, germline familial mutation, driving prostate cancer is in a gene called BRCA2. And many of you may have heard of this gene because of its association with breast and ovarian cancer, but it's also a prostate cancer gene. And then you look at the rest of these mutations. Here's BRCA1, these other genes, CHEK2, ATM. And what I see as a cancer researcher and somebody who looks at genetics, there's a distinct pattern here of genes involved in a process called DNA damage repair. So these are the genes that fix the daily damage that happens in cells in their DNA. And that's how cells maintain their health and survival over time, because there is this repair machinery. But of course, if the repair machinery is damaged, then mutations can accumulate more rapidly. And so this is the family of genes, in fact, that is targeted by PARP inhibitors. In familial BRCA mutations, so BRCA mutations, as I said, we think of this as being associated with breast and ovarian cancer, but in fact, it's also associated with prostate and pancreatic cancers. And traditionally, we think of at-risk populations, especially Ashkenazi Jews, certain Nordic populations, certain Mediterranean populations, and African Americans. And what you see here in the chart at the bottom is that for people who carry BRCA1 or BRCA2 mutations, their risk of prostate cancer is 3 to 9 times higher than the normal population. So really, these mutations are powerful drivers of prostate cancer risk. With BRCA2 especially, we know a lot because this is, as you saw a couple slides ago, the most common inherited predisposition gene for prostate cancer. And not only does it lead to more cancer, but it leads to more aggressive cancer. So BRCA2 driven prostate cancers tend to have higher Gleason scores, higher stage, a younger age of presentation. We also then recommend that these patients be treated as high risk and start their PSA screening at a much younger age. So as much as there has been a debate over the years about the role of PSA screening in prostate cancer, and over the last 8-9 years, you've seen the recommendations change and change again. In fact, the recommendations for this population never changed. Everyone always agreed that high-risk patients, such as those who have a BRCA2 mutation, should start PSA screening at the age of 45. Now, so that fact right there obviously emphasizes why it's important for a patient to know their BRCA status, right? If you know your status, let's say you have prostate cancer and you're a carrier, well, then, you can tell your siblings, right? Your brothers, your sisters, or potentially your children, that this is something that they need to be worried about. Amongst lethal prostate cancer, As much as 60% of carriers of these genes, though, don't have a family history of cancer. Right? And I make this point because one of the things people often say is, well, there's no cancer in my family, so I figure I'm fine. And of course, that's a natural thing to say. I mean, the logic is self-evident. We understand why people say that. But the problem is that having a gene like this increases risk, but it's not a guarantee. Like you saw on the previous slide, a person maybe has a 9-time greater chance of getting prostate cancer, but they still have a really good chance of not getting it. So it's quite common that people who actually have the gene don't have any family history whatsoever. And why do I make that point? I make that point for something we're going to say later, which is who should be tested for this. Okay. And part of the answer is it doesn't matter what the family history is. Any patient with high risk prostate cancer needs to be tested for these genes. Okay. So this is now a national recommendation. It is a national guideline from, really essentially every guideline issuing body. So the NCCN, that's the National Comprehensive Cancer Network, the Society for Urologic Oncology, the American Cancer Society, the American Society of Clinical Oncology, are all unified in saying that germline genetic testing should be obtained for any prostate cancer patient with high risk, very high risk, regional or metastatic prostate cancer. This is the most important message for today. Okay. I mean, your doctor is going to be able to counsel you about the PARP inhibitors and about how to take them. But what we're seeing in the community and the problem, the first step is getting tested, and people aren't getting tested, not often enough. So for all the prostate cancer patients and patient advocates and providers listening in on this webinar, the most important message is it is now standard of care and a national guideline that all of your patients with high risk or higher risk prostate cancer should have germline testing. So as a medical oncologist, right, I see advanced prostate cancer patients. What this guideline means is that I recommend germline genetic testing on every single patient I see the first time I see them. Right? So the question comes up all the time, when should I be tested? The answer is as soon as you develop high risk or higher risk prostate cancer. Okay. All right, so continuing on the genetics, we were talking there about the germline, right? That is the mutations that you can inherit from your parents. But now we have to talk about, well, what about the somatic, right? What about those mutations that that a person develops only in their cancer cells? It's not in your whole body, it's just in your cancer cell. And so prostate cancer cells accumulate mutations that make them different from healthy cells, right? That's what makes it a cancer cell. And what we see is that the rate of BRCA2 mutations doubles from around 10% in the healthy cells to 20% in metastatic castration-resistant prostate cancer. So that's prostate cancer that has advanced from being just in the prostate to being metastatic and now to being resistant to androgen deprivation therapy or Lupron. And so the rate of BRCA2 goes up by double. And this is indicative of what's happening with every other gene as well, right? The mutation rate advances as the cancer gets worse. But what this really emphasizes then is that testing for germline alone is not enough. What we actually have to do is 2 separate tests. We have to test the patient's germline mutations, and we have to test the new mutations that occur in the cancer later on. Right? So why test genetics at all, right? People push back and say, but why am I going to order that test? I understand it's a recommendation. Why should I do it? And the answer is 2 things. Number 1, to treat the patients. Now we have PARP inhibitors. So here I'm telling you 20 to 25% of patients will have one of these mutations. Well, these patients can benefit from a PARP inhibitor. But PARP inhibitors won't work in patients who don't have these mutations, right? In which case you're giving them an expensive drug that has some side effects with no meaningful likelihood that it's going to benefit the patient. So number 1, you do genetics so that you know how to treat the patient. But number 2, to protect the family. So if a patient has a germline mutation, an inherited mutation, then that patient, of course, shares 50% of their genes with each of their first-degree relatives. And first-degree relatives means parents, siblings, or children. So if a patient carries a cancer risk gene, then every one of those people has a 50% chance of also being a carrier, right? So the patient's brother has a 50% chance, the sister has a 50% chance, the children each have a 50% chance. And if a person knows that they're a carrier of these genes, then they can be more aggressive about screening, right? About trying to detect cancer early, because the best way to cure cancer is to catch it early before it metastasizes, right? So really, two very compelling reasons why genetic testing must be done. All right, so let's get back to PARP inhibitors. So how do PARP inhibitors work in these patients who have these specific mutations? And the answer is this thing called synthetic lethality, which it's a pretty cool phrase, right? Synthetic lethality. It sounds pretty slick. And what this is a process where a specific combination of two different damaged proteins or genes leads to cell death. And so what I'm demonstrating here in this little picture, okay, example number one, let's talk about the gene that's mutated or normal in the cell. If the gene is normal and the second gene is also functional, then the cancer cell is happy. If the first gene, like BRCA, is normal and you give a PARP inhibitor, nothing happens, the cancer cell is happy. If you have a mutated gene like normal, and you have no PARP inhibitor, then the cancer cell is still happy. But if you have a mutated gene, like in BRCA, and then you give a PARP inhibitor, then you have cancer cell death. Okay, this is synthetic lethality, and this is the mechanism that we're exploiting, right? So the cancer cell is actually quite happy to have this mutated BRCA gene, and in fact helps the cancer cell grow, makes it mutate faster, makes it more aggressive. It's something that the cancer cell is benefiting from until we come in with the PARP inhibitor, and then the thing that was helping the cancer cell becomes its critical weakness, and you get cancer cell death. Okay. All right, so let's shift into these two drugs. I'm going to talk about rucaparib first, and then we're going to talk about olaparib. And I'm just going in that order because this is the order in which they were approved by the FDA. And I always start, when I'm talking to patient groups like this, I want to give you the fully unvarnished FDA statement, so you can kind of take it in full, and then I'll break it down for you. So from the FDA announcement directly from their website, on May 15th, 2020, the Food and Drug Administration granted accelerated approval to rucaparib, or Rubraca from Clovis Oncology, for patients with deleterious BRCA mutation, germline and/or somatic, associated metastatic castration-resistant prostate cancer, who have been treated with androgen receptor-directed therapy and a taxane-based chemotherapy. So to unwind this a bit, what they're saying is that Rubraca is approved if a patient has a BRCA mutated cancer, whether that's the family genetics or the cancer genetics, and the patient has received at least one of abiraterone or enzalutamide and at least one line of chemotherapy with docetaxel or cabazitaxel. Rubraca is a pill. It's taken twice daily. It's really attractive in that sense, right? It's not an IV that you have to come in to the office for. It's something that you take at home. And in the clinical trial that led to approval, Rubraca was given to most patients as third-line therapy, right? So after Abi or Enza, then after chemotherapy. And the reason it was approved because it showed tumor reduction in the majority of men. Now, just by way of comparison, chemotherapy leads to tumor reductions in maybe a third of cases. Here, over 50% of men saw a measurable reduction in the tumors. And it was effective for more than 6 months in most of those men who had tumor reductions. And in some patients, we've seen it effective for more than 24 months. In my own practice, I have several patients now who have been on these drugs for more than 2 years, and in fact now more than 3 years. There are side effects, of course, with all these drugs, and the most common side effects with Rubraca were fatigue, nausea, anemia, increased liver enzymes, decreased appetite, rash, constipation, low platelets, potential for vomiting, and some diarrhea. And this is taken directly from the FDA statement. So there are potential side effects, but clinically, because this is a pill that a patient takes twice a day, what that means is the side effects don't tend to come on too quickly, right? They build up over time. And it's fairly easy for me as a treating clinician to make the necessary adjustments to a patient's dose, right? To make sure that none of these side effects get too bad. Now, I try not to get into too much fancy graphs or complexity when presenting to patient audiences, but this slide is really quite compelling, and I think it really tells a clear story. So what this slide is showing you, this is a bar graph where each bar represents one of the patients with a BRCA mutation who was on the clinical trial. So all these patients got Rucabra, and what this shows is what happened to their PSA. So if the PSA went up, then you have a line going up. And if the PSA went down, then you have all these lines going down. So what you can see, right, is that the vast majority of patients had significant declines in their PSA. And, all these patients over here had a greater than 90% decline. And everyone below this gray line had a greater than 50% decline in their PSA. So really, you can see represented here how effective this drug can be. All right, so shifting then to olaparib, Lynparza. So as I said, this was approved just 4 days after Rucapra. Olaparib, per the FDA announcement on May 19th, 2020, the Food and Drug Administration approved olaparib, Lynparza, AstraZeneca Pharmaceuticals, for adult patients with deleterious or suspected deleterious germline or somatic homologous recombination repair gene mutated metastatic castration-resistant prostate cancer who have progressed following prior treatment with enzalutamide or abiraterone. Now, this statement is a little bit different from the prior statement in a couple of key ways that I always want to point out for patients. Number one, remember the Rucabra statement just talked about BRCA. The Lynparza statement is broader. It talks about the whole family of homologous recombination repair genes. So this is a longer list of genes, most of which are very uncommon, but nevertheless, this covers more than just Rucabra did, more than just BRCA. And for Lynparza, the approval only requires treatment with one of enzalutamide or abiraterone. There's no requirement here that the patient must have had chemotherapy. So currently, Lynparza can be given on-label prior to chemotherapy. Rucabra can only be given on-label after chemotherapy. So Lynparza, that is also a pill that's taken twice daily. So here again, fairly easy to manage. There's certainly advantages to pills over IVs. And in the clinical trial leading to approval, Lynparza was given to most patients as second-line therapy, right? So Rucabra was mostly third-line therapy. Lynparza was mostly second-line therapy. And Lynparza was proven to be more effective than the other established treatments at shrinking tumor and lowering PSA. So this was a randomized trial where half the patients went on Lynparza, half the patients went on other approved prostate cancer therapies. And Lynparza was clearly superior to those other options. And it was also effective for a longer time than the existing therapies and ultimately helped patients live longer, right? Which, is really what we're looking for is longer life, good disease control with better quality of life. Most side effects, and here again, this is taken, straight from the FDA, were anemia, nausea, fatigue, decreased appetite, diarrhea, vomiting, low platelets, cough, shortness of breath, and blood clots. But here again, these are really quite manageable in the clinic because we're managing the patient in real time, right? We're watching for these symptoms, we're watching the blood tests, and we're able to adjust the dose of Lynparza. And, oh, sorry, I went a bit out of order, so I'll back up. So this is my third slide about Lynparza then. So this is a graph, and here again, I just like to show a few graphs, but what this graph is showing, these two lines, this green line is the patients who got Lynparza, the blue line is the patients who got the control arm of the trial, so mostly enzalutamide or abiraterone, okay? And this is showing survival. How long do the patients live? And so as the line is coming down, that means patients are passing away, okay? And as the line is moving out, that's how long they're alive. And what you can see is the patients who got Lynparza lived about 31% longer. Average, median, right? 50% line of 19 months versus 14.7 in the control arm. But here again, you still have a quarter of patients doing well, 2.5 years later, despite the fact that this is advanced disease. So the question that comes up then, right? And people like to ask, well, which one should I do, olaparib or rucaparib? And the answer, the appropriate answer, right? The only answer is we don't know. Okay. These drugs were studied in different populations. They weren't compared to each other. So, I think one of the things that the public has probably learned during all this COVID pandemic and all these, reports that come out of the media and whatnot is how difficult it is to do good science and good clinical trials, and how important it is that we don't jump to conclusions and overinterpret results, right? So, I'm being a bit kind of regimented here, but truly we cannot compare the results from these two studies to each other. They were different populations, given at different time points. So we really don't know which one of these drugs is better. What I would tell you is that I think they're in the same ballpark, right? I think there's only fairly minor differences between them. They are both highly effective drugs. So in picking one or the other, I think the honest and appropriate answer is that we can't compare the data for the two drugs, but they are both good drugs that are both highly effective. But as I said, there are slight differences in the FDA label, which really should be respected. Okay, the labels are written a certain way for a reason. It's because that's what the data tells us, and I would encourage providers to really stick to the label. All right, so is that all? No, right? Not at all. There are two other PARP inhibitors in advanced stage clinical trials, talazoparib and niraparib. They're being tested in very similar, but slightly different trial designs to what we just talked about. And based on early data, I think we expect these to also be positive. So, it sets up what's probably a very nice situation for prostate cancer patients, which is having, a lot of different options, right? And the more options we have, the better. Because what'll happen is that those of us who are the cancer researchers, we will start working out which one of these drugs is better for which patient. But of course, we can only optimize treatment if we have options. There's a lot of studies going on trying to combine PARP inhibitors with other drugs, including some of these, oral hormone agents like we talked about, abiraterone and enzalutamide, but also studies trying to combine PARP inhibitors with immunotherapy. Because there is some exciting early data suggesting that the way PARP inhibitors interact with this prostate cancer cell actually makes the prostate cancer more susceptible to immunotherapy. So most of you probably know that in prostate cancer, we still haven't cracked the code of how to make immunotherapy work. Maybe this will be part of the answer. And then there's also many studies looking at using PARP inhibitors earlier. So these two drugs, like we talked about, are approved for very specific settings where the patient has been treated with certain drugs beforehand. But studies are already accruing, already underway, trying to move PARP inhibitors up to the front of the line rather than second or third line therapy, but looking at it in first line, or even looking at PARP inhibitors as pre-op treatment. Can we shrink a prostate cancer before surgery and maybe make the surgery safer and with fewer side effects? Can we combine PARP inhibitors with radiation therapy? Again, maybe we make the radiation more effective and decrease complications. So all of these various possibilities are being looked at. And I would say you're gonna hear a consistent stream of data coming out about PARP inhibitors in prostate cancer for the next several years. And for any patients listening to this, I would also encourage you to ask if there are clinical trials that you could participate in, right? I mean, that's one of the other lessons I hope that the public took away from this whole coronavirus experience is the faster we stand up studies, get patients on them, and get results, the faster we can solve this problem. But if people don't go on the studies, then we're stuck and we can't move forward. So take home messages. PARP inhibitors, without question, are a revolution for the treatment of prostate cancer. These are the first genetically targeted therapies available for prostate cancer patients. Other cancers have had genetically targeted therapies for years: breast cancer, lung cancer, colon cancer. But this is now a first for prostate cancer. And I tell you, it won't be the last, because there are other gene targets and other drugs for those targets that are being tested in prostate cancer. So you're going to hear a lot more about this type of therapy in prostate cancer in the coming years. PARP inhibitors are relatively well tolerated by most patients. I think, everyone's kind of gotten used to these long lists of side effects that we talk about with all these drugs. But truly, these are fairly easy drugs to manage. And I can tweak the regimen for the individual patient to find that balance point of a dose that works to treat the cancer while preserving the patient's quality of life. And I've had multiple 90-plus-year-old patients on these drugs at maybe half dose or less, right, where we just fine tune the dose to make sure their quality of life is preserved while we attack the cancer. Genetic testing is the key. PARP inhibitors only work when the mutation is present, right? So prostate cancer patients need to get their genetic testing done in order to know if they're going to benefit potentially from PARP inhibitors. And of course, like I said, the single most important take-home message I hope everyone carries with them is that every man with metastatic prostate cancer should have genetic testing. The data we see makes it pretty clear that this is not happening. It's really only a small percentage of men who are having genetic testing. The number should be 100%. Every man with metastatic prostate cancer should have genetic testing. All right, so thank you very much for listening. The link here is is the Mayo Clinic website, and if you have questions or would like to request information or even an appointment for Mayo Clinic, you could certainly do it through that website. Thank you very much.
Thank you so much, Dr. Bryce. What a great update on PARP inhibitors. I know there was so much excitement in the prostate cancer community when these new treatments were approved. So thank you so much for that great update.
My pleasure. Thank you for having me.
I wondered if you could chime in just a little bit on, I know what's the top of everyone's mind is just the cost of what these treatments are going to do to a man and his family's pocketbooks and their families as they think through, what goes into a prostate cancer diagnosis. Can you share or expand on that at all?
Yeah, it's a very important topic. I mean, without question, it's something we manage in clinic on a daily basis. And, these are branded, expensive drugs without question. And they'll get billed through insurance. And if Medicare, goes through Medicare Part D. And so what, typically is going to happen is that, 90+% of the expense is picked up by insurance, but then the patient and his family have a copay to deal with. And I've seen that copay be quite small, but I've also seen it be, a few $100s a month, for example. And, so it's very important to the credit of the drug companies, both Clovis Oncology, AstraZeneca, and Merck, who produce these drugs, that they have very robust patient assistance programs. So I would encourage patients to allow the doctor to kind of go through the process, because the way it works is we'll submit the prescription to the pharmacy. In my practice, I have a pharmacist who deals with this specifically. We'll work on getting the approval. And then if the copay is really excessive, then these copay assistance programs can really kick in to help patients. And like I say, the drug companies really have been very good about making sure that patients have access. and trying to make sure that no one is left without their medication. So, it's not a small issue. I mean, we know that, and I think the pharmaceutical industry is very aware of that as well. But ultimately, at the end of the day, we're able to get these drugs for most patients because the copay assistance programs are really quite good.
Yeah, they really are. I'm so glad you mentioned that. The pharmaceutical companies that Zero gets the opportunity to work with and generously sponsor so many of our wonderful education and patient program events. Their programs are great. And I will say just a brief plug for one of Zero's patient assistance programs is called 0360. It's a comprehensive patient support program. And hundreds and hundreds and hundreds of callers use 0360. And I think since its inception, we've saved about $2.7 million for patients. So we're something we're really proud of, and callers can get financial assistance, but they can also tackle that psychosocial, emotional support that goes along with the diagnosis. But I'm very glad that you touched on that. One other item I wondered if you could dive into a bit is just the BRCA gene and what that means for a family. I mean, I think it's very common in breast cancer. It's called the breast cancer gene because that's how it was discovered. But what does that truly mean for both men and families and women and families?
Yeah, absolutely. This family portion of it is critically important. I mean, I will tell you, one of the things that'll happen in my practice once every couple of months that I look at as one of the greatest victories we get is when, we have a patient, a man that we've tested for the BRCA gene, right? He tested positive. He talked to his family about it. The kids get tested. And then, his daughter finds out she had a stage 1 ovarian cancer that they cured, right? And, this is a cancer, for example, I mean, I've had it happen a couple times. I mean, this is a cancer where usually it's advanced before it's diagnosed because it's hard to detect, right? And, quite likely we've saved this young woman's life, right? And that's a win. That's a massive win. It's one of the critical pieces, like you talked about. BRCA is called the breast cancer gene. And still what's happening in clinic, because information takes time to disseminate, right, is, women go and they talk to their primary care doctor, and their primary care doctor asks them about their mother and their sisters. Mm-hmm. Is there any breast cancer in the family or ovarian? Because they're screening for BRCA. But of course, they also need to ask about prostate and pancreas, mm-hmm. right? And the same thing for the men. I have it happen all the time. I'm in clinic. I ask a man, all right, well, tell me about your family history of cancer, any cancer in the family. And he tells me about his father and his brother. And I say, well, what about your mother? He'll say, well, she didn't have prostate cancer. I say, yes, sure, I know. But did she have any other cancers? So these cancer genes are not gender specific. It's part of the important point. And it really affects, both men and women alike.
Right. And family history is something that, some families, some cultures don't really talk too much about with one another. So I think it's an important message for parents, adults, and also children. Don't be afraid to really poke and jab at your family members, to really understand their family history, because it could ultimately be a game changer for your own life.
Well, I mean, let's talk to the men listening, because, some of them are probably sitting there listening with their wives, right? Sure. So here's the conversation I have in clinic all the time. I ask the man, so is there any cancer in your family? And he looks at his wife and he says, honey, is there any cancer in my family? Like, you don't know your own brother, and she knows, the guys are all laughing because they know it's true.
Absolutely. Yeah, no, that's such a great point. And in the prostate cancer space, far too well, the caregivers are so important too. And so we're so grateful for our caregivers in the prostate cancer community too, both for being the nagging, sometimes spouse or partner, but we'll take that. That's okay.
Yep, that's right.
But thanks again, Dr. Bryce. We so appreciate you being here with us today, truly helping us understand a semi-difficult topic to fully wrap our brains around. So thank you so much. We're so honored you could be here and be a part of our 2021, unfortunately, virtual Prostate Cancer Summit.
Yeah, well, hopefully we'll be back in person next year.
Absolutely.
Thank you so much for having me. Yep.
Thanks.
The issues you care about most are right here at the virtual Zero Prostate Cancer Summit. Please check out the other topics, sessions, and virtual get-togethers in your Summit app. Remember, you are not alone. Join the Zero community to gain support and more information on prostate cancer at zerocancer.org.